Good morning, everyone. Thank you for participating, and thank you for having me as a speaker this morning. My name is Andy Zinn. I'm an interventional cardiologist at Cooper and Inspira, and I'm the director of the Catheterization Laboratory in Vineland. And today I am going to talk a little bit about percutaneous left ventricular assist device use in the catheterization laboratory. But before I do, I just want to say that I really enjoyed Dr. Corrin's talk, and I also really appreciated his comments about telemedicine and online conferencing. And I do think that we've been forced to expand our access both for education and for patients. Now, obviously, there are some things that cannot be done remotely, like interventional cardiology. However, that's not entirely true. So while Dr. Corrin was giving his talk, I decided to add a little bit of a slide to my talk. So this is a brand new slide that I just put in. And it's a paper that was published earlier this year at the height of the pandemic, when personal protection equipment was in short supply, or there were concerns about running out of equipment. And this is actually a study well, not a study, but a case report that demonstrated the use of robotic-assisted percutaneous coronary intervention in COVID-19 patients. And the system, you can see it down here at the bottom of the slide. And it's, it can't be completely robotic. Arterial access has to be obtained by a live operator, but subsequently, most of the procedure can be done remotely. So even interventional cardiology and some surgical techniques may expand into the sort of telemedicine realm. At any rate, with that little divergence, I'll get back to the topic. And what I'm going to do is spend a couple of minutes going through some background on ventricular assist devices and cardiogenic shock. Then I'll show you a couple of the major devices with an emphasis on an Impella device, which is probably the most robust device that we use regularly in the catheterization laboratory. And then I'll show you an illustrative case from a couple of years ago. So when we talk about mechanical circulatory support, specifically, we're referring to devices that provide hemodynamic support in a number of clinical scenarios, okay? So percutaneous devices can be inserted in the cath lab for short-term support, and more permanent devices can be surgically implanted for longer-term support. All right. Today, I'm really going to be concentrating on the percutaneous short-term devices that we use in the catheterization laboratory and at the bedside. Here are some important terms that I'm sure many of you are familiar with. An intra-aortic balloon pump. A VAD is a ventricular assist device. Again, it can be percutaneous or surgically implanted. You have LVADs, which are left ventricle or left ventricular assist devices, RVADs, which are right ventricular assist devices, and ECMO systems, which are extracorporeal membrane oxygenator pumps, but can be implanted percutaneously. The typical indications at our cardiac partner sites, so these can be put in both at Cooper and in Inspira. So very high-risk percutaneous coronary interventions, usually the devices are put in just for the duration of the intervention, or cardiogenic shock, often acute myocardial infarction complicated by cardiogenic shock, sometimes with mechanical complications like acute ischemic mitral regurgitation or a VSD, a ventricular septal rupture. Other indications might include heart failure during a period of stabilization, when you're trying to make decisions about long-term management plans. These devices can be used also to support high-risk percutaneous valve procedures, or even EP procedures like VT or VF ablations. And it can be used to support patients with medically refractory arrhythmias, such as refractory ventricular tachycardia associated with ischemia or poor pump function. Now, just to pivot a little bit and talk about cardiogenic shock, I know many of you take care of patients with cardiogenic shock either on the floors, in the intensive care units, or en route to the hospital. Cardiogenic shock is defined as critical end organ hypoperfusion as a result of poor cardiac output. The typical criteria include hypotension with a systolic blood pressure less than 90 for 30 minutes or greater than 90, but relying on vasopressors, associated with pulmonary congestion or elevated filling pressures. The signs that one would look for, either in the field or at the bedside, would include altered mentation, oliguria, cool, clammy skin, and of course, an elevated lactate. The etiology is often due to post-myocardial infarction complications such as severe LV dysfunction, the mechanical complications I spoke about a minute ago, like acute mitral regurgitation, but it can also be iatrogenic. Remember, we use heavy-duty blood thinners for patients with myocardial infarction, and they can bleed. A lot of the medications we use for heart failure can also cause hypotension, and if given too quickly and too robustly, can cause problems. And there's also a laundry list of other causes of cardiogenic shock. I won't go through the whole laundry list here, but it's everything from myocarditis, maybe in a young patient, to dissection or tamponade. So there are many different things, obviously, that can cause cardiogenic shock. Now, the point of this slide is just to demonstrate that shock can be very subtle, all right? So in one of the largest studies of myocardial infarction, less than 1% of patients had shock on admission, but about 5% developed shock during their hospitalization, and half of those patients developed shock early on within 24 hours. Patients can have recurrent chest pain, dyspnea, altered sensorium, hypotension, tachycardia, tachypnea, JVD, new murmurs, extra heart sounds, rales, cool and clammy skin. But I really want to illustrate this important point at the bottom. In the pivotal shock trial, 1/3 of patients had no pulmonary congestion, and 5% of patients had hypoperfusion, but had no overt hypotension. So we really rely upon our frontline workers, our nurses, our EMTs, to identify patients with subtle signs and symptoms of cardiogenic shock so that these patients can be adequately resuscitated early on and treated appropriately. Now, what is the rationale for these mechanical circulatory support devices? Well, when you use pressors, all right, and when you have a lot of inflammation in general from cardiogenic shock, catecholamines increase myocardial oxygen consumption, and vasoconstrictors impair microcirculation and tissue perfusion. Vasopressors and inotropes are limited in their ability to maintain adequate tissue perfusion, and mechanical circulatory support devices can help reverse the process without relying on some of these other interventions. In the cath lab, again, we can use balloon pumps, percutaneous VADs, and sometimes ECMO. When we look at randomized trials in cardiogenic shock, as you can see, many different interventions have been studied. Revascularization, various kinds of catecholamines, meaning pressor therapy, and other medical interventions. And in addition, at the bottom of the slide, we've looked at intra-aortic balloon pumps and VADs. What we have found is that the only intervention that has reliably decreased the risk of mortality is revascularization. And that's the reason that our emphasis, especially in STEMI, is always on door to balloon time and revascularization. When we look specifically at percutaneous LVAD supporting cardiogenic shock, we find there are a couple of trials that have been done. And while the VADs will result in higher cardiac output, higher mean arterial pressures, and lower pulmonary capillary wedge pressures, they also lead to more bleeding and inflammatory complications. And there's no 30-day mortality benefit that has yet been demonstrated. Now, I have seen a lot of data and a lot of editorializing on this topic. And the truth is, it's very, very hard to study shock. And it's very hard to study mechanical circulatory support. The randomized trials tend to have small numbers and are underpowered, and more studies are definitely needed. The same goes for using Impella specifically in high-risk percutaneous coronary intervention. The pivotal trial was the PROTECT 2 study. Over 600 symptomatic patients with complex multivessel coronary disease or unprotected left main disease and a low EF were randomized to either Impella or a balloon pump. And interestingly, there was no difference in 30-day rates of major adverse cardiac events. But if you did a per protocol analysis, which is only considered hypothesis generating, one finds that Impella use did lead to reduction in MACE. The bottom line, additional studies are definitely needed with newer devices that have unique advantages, like providing enhanced levels of flow, smaller sheet sizes, and other more user-friendly attributes. So the take-home point when we talk about mechanical circulatory support in general, and when we talk about cardiogenic shock, is that for now, the only therapy that's really proven to improve outcomes is revascularization. Randomized trials of mechanical circulatory support have not yet shown prognostic benefit in either shock or protected percutaneous coronary intervention. But this area is difficult to study, and more definitive data from larger registries and randomized controlled trials is definitely needed. Okay, so now we're going to concentrate for a few minutes on the devices themselves and the use of Impella in percutaneous coronary intervention. So this is a schematic of the various devices that we use. Most of you have probably heard of intra-aortic balloon pumps and Impella. Those are the devices that we typically use at Cooper and at Inspira. Now, tandem heart devices are older devices that are not as frequently used anymore. And ECMO we do use, and you won't see it used as frequently as the other devices because it's a little bit harder to implant and also a little bit harder to support. I just showed this slide to illustrate that we have mechanisms to support the RV percutaneously as well. The Impella RP is a right-sided Impella device. It's shaped a little bit differently to allow for passage into the right heart and the pulmonary artery. ECMO can be used to support the right heart, and there are a couple other catheters that can be used as well. Now, intra-aortic balloon pumps are inserted via the femoral artery. And they're not very big. It's only a 7.5 French sheath, which is pretty small relative to some of the other support devices. What it does is it deflates during systole, which provides some afterload reduction. And it inflates during diastole to augment central and coronary perfusion pressures. There's been an inconsistent benefit demonstrated in numerous observational studies, no benefit demonstrated in the contemporary intra-aortic balloon pump shock trial, and that's the graph that's shown on your right. There was no difference in mortality. And we think that the utility may be limited to patients with mechanical complications of myocardial infarction. All that being said, the shock trial, which was not designed to look at balloon pumps, the majority of patients did receive a balloon pump in that trial. And it's still probably the most widely used support device throughout the United States. So you will see a lot of them put in. Now, the two main percutaneous LVADs, I already mentioned the tandem heart, and I'm not going to go through it in a lot of detail. The tandem heart isn't used as frequently as we used to use it. It's kind of a big, bulky device, and it's somewhat hard to use. But the way it works is you put it in through, you put a cannula in a vein and a cannula in the artery. From the femoral vein, you go up to the heart, you go across the atrial septum, and then you put a large cannula in the left atrium. You drain blood out of the left atrium, and you dump blood back into the femoral artery, and provides up to 4 liters per minute. Right? Now, the Impella device, I'll show you a little movie in a moment, but the Impella device is very user-friendly. It's a pigtail catheter, which means it has a little curly Q at the end. It has a microaxial pump. And what you do is you go into an artery and then you cross the aortic valve with the pigtail. You suck blood out of the LV, and then you dump it into the ascending aorta. It decompresses the left ventricle and provides flow. It can provide anywhere from 2.5 to about 5 liters per minute. Some of the larger devices are put in surgically through small cut downs, either in the axillary or the subclavian, although we have now developed percutaneous methods to implant and also to explant these devices. So this is a little illustration of the device. So again, it goes up through the aorta, through the femoral artery, goes retrograde across the aortic valve, and then you can see the pigtail sitting right in the left ventricle. There's an inflow cannula, so blood goes into the inflow cannula, and then the blood goes out through the ascending aorta, and you get increased end organ perfusion and renal protection. All right. Okay, so now what I'm going to do, and this will probably take another 5 or 10 minutes, and then we'll be open for questions. I'm going to show you a real case. This was a case from a few years ago, but it illustrates a lot of what we've already spoken about. So the patient was a 79-year-old woman with a history of dyslipidemia, mild dementia, and former tobacco use with fairly advanced COPD, but at the time of presentation, she had no known coronary disease or congestive heart failure. She presented with chest pain and volume overload. Sorry about that. And an echocardiogram revealed an ejection fraction of 10%. Left heart catheterization was performed and showed severe distal left main disease, extending into the proximal LAD, highly calcified. In addition, she had a chronic total occlusion of the proximal left circumflex, a chronic total occlusion of the RCA. Her EF in the cath lab was also 10% with low cardiac output and an elevated wedge pressure. So she was placed on milrinone, which is an inotrope, and an intra-aortic balloon pump was implanted, and she was referred for cardiothoracic surgery. Her STS-PROM, so the Society of Thoracic Surgery's predicted rate of mortality, was 35%, and her combined morbidity and mortality was 82% with CABG. So this is a score that's used to predict the rate of death or major morbidity and death as a combined endpoint if a patient undergoes CABG. Given the prohibitive risk, she was turned down. So after long discussion with the patient and her family, we decided to proceed with percutaneous intervention. Okay, so this is her baseline angiogram. Okay, and what I'm going to point out here, and I'm not sure if my cursor works as a pointer here or not, but what you see at the very top of the screen is the catheter injecting into the left main coronary artery, and then there's a severe narrowing in the left main, and then the blood vessel running down on the right side of the screen is the left anterior descending artery. So that would be this here if my pointer is working. And the other thing you see here is that there's a vessel sort of on the left side of the screen that ghosts in a little bit late. And that's the left circumflex filling through collateral blood channels. All right. So severe left main disease, severe LAD disease, and a circumflex that's totally occluded and collateralized. Now, on the right side, what we see is stump occlusion of the right coronary artery in its mid-segment. And I don't show you this, but we do have other images that show that this area is also well collateralized through the left main. So what we're looking at here is a situation where you have severe left main disease, severe LAD disease, and your two other vessels are supplied through collaterals. Perfect anatomy for bypass surgery, but again, this patient is not a candidate for bypass surgery. So obviously a very high-risk intervention. So what we've done here is we've brought her back to the cath lab and we've put in an Impella device. The Impella device starts up at the upper left of the box at around 11 o'clock, and then you can see the pigtail down closer to 4 o'clock. There's another little support device in there crossing the impella, and that's actually a transvenous pacemaker. Once we had these support devices in place, we felt comfortable intervening on the left main coronary artery. And what we did is we started with rotational atherectomy, which is a microscopic drill that you place into the artery to get rid of calcium. Okay. And then after we had debulked it with calcium, we were able to inflate a balloon. So that's what you see sort of right underneath 12 o'clock. So again, if the pointer is working, that's right there. So we see a balloon being inflated. And then after that, we put in a stent, and you can see we have a very nice result. Now, in this case, I do show, and what's ghosting in at the end of the run here, what I do show is the right coronary artery flowing through collaterals. So we stented the left main coronary artery and the LAD. Okay, we did not try to intervene on the chronic total occlusion of the left circumflex. There are some techniques that would allow you to do that, but it's a little complicated because of the need to stent the left main. But what we did do is we let her recover for a couple of weeks, and then we brought her back electively to do to try to intervene on the chronic total occlusion of the right coronary artery. So what I'm showing you here is called a dual injection angiogram. I have a catheter in the left coronary and a catheter in the right, and you inject both simultaneously so that you can see the full length of the right coronary artery, filling both through an antegrade injection, but also through the collaterals. And that's what you see here. The right's being injected, the left's being injected, and you can sort of see at around, I would say, 10 o'clock, the gap. And you can actually see that the gap is not that big. Sometimes it's sort of misleading how long a chronic occlusion is, but when you do these dual injections, you can kind of tell. Now, in this situation, we did not put in an impella. We had already revascularized the left side. This side was chronically occluded. So when we began to intervene, it wasn't really feeding much. So we felt comfortable doing this without an impella. We were able to cross that chronic occlusion using some special chronic total occlusion catheters. We were able to inflate a balloon. And then once that was done, we implanted a stent, and we got a very, very nice result, as you can see there. So now we're in a situation where instead of having severe left main, severe LAD, and a chronic total occlusion of the right and the circ, we have revascularized left main, LAD, and RCA, and a circumflex territory that's well supplied by collateral blood vessels. So the patient received stents again to the left main, LAD, and right. We left the circ alone, but it filled via collaterals. Subsequently, she underwent ICD implantation and was continued on guideline-directed medical therapy. She had marked improvement in her ejection fraction. It improved to the 40 to 50% range and no heart failure symptoms, and she survived an additional 5 years with no hospitalizations for angina, non-STEMI, or congestive heart failure. She eventually passed away in her home in her mid-80s, actually last summer. So just to conclude, cardiogenic shock is characterized by critical end organ hypoperfusion due to poor cardiac output. Despite its perceived utility, percutaneous mechanical circulatory support has not yet been shown to improve outcomes in high-risk PCI or cardiogenic shock. However, it is certainly very useful, as I demonstrated in this past case, and additional studies are required and are ongoing to determine if a prognostic benefit exists. The usual options are intra-aortic balloon pumps or left-sided impella devices. VA ECMO can sometimes be used to support the left-sided circulation. And right-sided support, again, can be done with another impella device, or VV ECMO. Biventricular support can be done with more complex ECMO systems. Bipella, which would be a left and a right impella at the same time, or ECPella, which would be a combination of ECMO and impella implanted at the same time. And that's all I have. I appreciate everybody's attention today. I hope you learned something. There's my office number, my cell phone number, and my email. So feel free to contact me with any questions about this presentation or anything else in general that you hear about today. I would be happy to answer any questions.